So we look at people with back pain. This is a group of people with persistent back pain, around 300, that were investigated by Martin Raby, one of our PhD graduates. And he found that there were these three clusters of patients. And this is looking at their psychological profile. And this looked at things like their stress, their anxiety, their level of depression, pain catastrophizing, their self-efficacy. There was a group of people who had both high levels of emotional distress and very negative beliefs around their pain and low self-efficacy. There was a group who had predominantly negative beliefs around their pain and low self-efficacy, but not really, really high levels of distress, emotional distress. And there was a group who were low. And the interesting thing when you start profiling levels of emotional distress and your beliefs is you start seeing something that's quite interesting. The more distressed a human being becomes around pain, we see that their pain levels are higher. We see that they're more disabled. We see that they're more bothered by their pain. We see that they report more significant life stress events. So life stress events can have a profound impact on our nervous system as it tracks through time. Particularly early life stress factors can set a vulnerability through the lifespan. We see that they're more susceptible to increasing in pain with movement. We see they're more likely to report they feel perceptual differences in terms of where their body is in space. They're more sensitive to touch. They've got more undiagnosed comorbid symptoms like fatigue, dizziness, headache, migraine, and other symptoms. So we see that the higher the level of distress, the higher the burden. And if you look at within the health system, the most disabled people, the people taking time off work, the people who are really in trouble are those who are really suffering from this problem. And of course, it goes two ways. You know, pain causes distress, and distress can cause pain, and becomes part of that cycle. So within a clinical setting, we've got people who are coping really well. We've got a bunch of people who are pretty distressed with pain. We've got a bunch of people where they may have comorbid mental health problems. That just becomes part of that package. And when we look at something like taking time off work, we just got to finish the paper, that we've looked at people with mental health problems, like a diagnosed mental health problem, and we look at people with back pain. Both of those groups are likely to take more time off work. If they have the two of them, it has a multiplying effect. So you start combining them, it's just a bigger burden. So what about the things that people think? We know that there are so many people who are thinking terrible things, and that is not their fault. They've been told this stuff. They've been told their pelvis is out. They've been told their ribs are out. They've been told that their legs are long different. Their arches are collapsed. Their core is weak. That their bones are crumbling. That they're vulnerable. Now, why would you tell a vulnerable person they're vulnerable? It doesn't make sense. And so we rip out the confidence of people who are vulnerable by telling them that there's something wrong with their body. There may be something wrong with their nervous system, but to tell them there's something damaged with their structure does nothing but defeats them in that process. And so no wonder these patients are thinking bad stuff. No wonder they think they're going to end up in a wheelchair, or they won't be able to function, or they can't work, or they can't play with their kids, or they can't lift their child, or they can't have a baby, and all this stuff, because often they're told it. So what do we know about negative beliefs and fear and low levels of self-efficacy? It predicts disability. You know, when you're thinking this stuff, you behave like you're damaged, and of course you will if you believe it. And sadly, so often this comes from the negative information that we give. And I'm the first to put my hand up to say I have told people some dreadful things in my career. I've told people that if they do repetitive bending, the nucleus is going to pop out of their disc and they could be vulnerable. I can remember as a young physiotherapist in New Zealand, people coming in, I say, can you bend over? They go, I don't do that. I go, what do you mean you don't do that? Well, I don't do that because the disc could pop out. We have created that myth And we've spread it, and it's on the internet. You can see graphic examples of when you load the disc, the nucleus squeezing out the back, or when you bend the back, that happens. People have these graphic images on their mind of the vulnerability of the human structure just to do normal stuff like putting on your shoes. So what do we see? People don't do that. Why would you? Why would you bend your back if your risk is your disc will prolapse? Because that's the messages that we're giving. Vulnerability.